there is a pipeline out there of new drugs. You've been talking about them. Let's just nail it. There's atacicept. There's placibimod. I'm going to try this one. Epertuzumab. How'd I do?
Perfect.
I like that. Tabalumab or tabalumab. These are drugs that are out there. They're in the pipeline. Where do they fit in with all this?
I think that several of them may get to the point of FDA approval, but we'll still be having this discussion because we will not have personalized biomarkers to decide which one to use, and we still will not have long-term outcomes. Because as you know, for the most part, randomized clinical trials will be 1 year in length. We can try to generalize from longitudinal cohort studies, but we will not have perfect outcome data on which to make medical economic decisions.
All right. That leads me to the last question in this section. We're going to get on to the next section, which is we've been using a metric here that we implicitly agreed upon, and I want to call everybody out on it, including myself. We've been using money, right? You said, okay, it's an expensive drug. Prove to me it'll save money elsewhere. Decreased hospital administrations, decreased surgeries, whatever. Maybe, just maybe, an expensive drug makes people feel better. They still cost you a lot of money, but their life is better, they enjoy their life better, and it's expensive. How much is life worth? Aren't some of these drugs expensive, and maybe they'll make people feel better, and we're just going to eat the cost? What about that?
Well, in the U.S., we haven't defined what that threshold should be. Other countries have. In the U.S., I think we're still trying to use, we're not trying to ration care. I think we're trying to still understand right drug, right patient. We use prior authorization to try to define what is FDA approved or perhaps even studied to be able to say yes. And I'd actually argue with you that we're not that's because of cost, but we're not saying no to a drug because of cost. I think other countries are a bit different.
Yeah, I think in terms of defining the value of a medical therapy, you probably have to ask the patient as well. I don't think anyone in the world of hemophilia is a fan of promoting use of therapies that don't have some benefit for patients, and most of them we think have measurable outcomes.
But let me stop you. I'm not saying they don't have benefit, but by his rationale, because I heard him say it, I'm just going to pick on you for a minute. The benefit isn't measured in money. In other words, the benefit may be I feel better, the benefit is I can do more things. It isn't necessarily every time translated into decreased hospitalizations, decreased cost of care, decreased money spent on this patient. Can we get away, should we get away from money as the ultimate metric?
Well, I think there's an economic consideration even when it comes to improved quality of life, and I think it should be demonstrable probably for patients who are deriving a lot of benefit out of a therapy.
I want to ask managed care to allow me, the practitioner, to make an individual decision for that patient.
Because you know the therapy has a good chance of giving that patient something
well,
which has
let's
value.
say a fair
Right.
chance.
Right.
It may not even be
Right.
good, but if there's no alternative,
Exactly.
I want to have that patient have that opportunity. And I'm very willing at 6 months or 12 months to tell managed care how that patient is doing, and at some reasonable time, give up. But I'm going to have to individualize it now because I don't have that formula. I can't plug my lupus patient into a formula.
But maybe what we need, and I'll use rheumatoid arthritis as an example.
So you take it off the table from either of these guys.
But I think there what we see is actually the role of a functional assessment that is built to a guideline that can help us understand, is that drug working? And the goal is remission. But in terms of what we're discussing here, which is what is the patient's role? How do we know the drug's working? What's the impact on quality of life and functional assessment? And hopefully we'll have that long-term data to say if patients are feeling better, they should be consuming less resources. They should be out of the hospital. And oh, by the way, we're saving organs as well, and patients are living longer. But I think we need something that's validated and that hopefully we can collaborate and agree to.
Again, that the academic community will work on those things, but they don't exist now. So allow me the flexibility to decide that patient A should stay on the biologic because her flare rate went down, and patient B because her requirement for prednisone went down, and patient C because her quality of life is better. But there won't be one size fits all.